All right, this part is not in the notes. I added it in, so don't worry about doing it on tests and things like that. But I think it's important because you probably see a lot of this, maybe more so than like a facet sprain. So again, when we talk about as the facets move into extension, they compress the facet joints. So the actual, again, we talked before, you have the facet joint is an actual synovial joint. So it has cartilage, it has a capsule, it has a synovial membrane, and then there can be, and then there's some sensory innervation to it. And typically, if they're going to talk about lumbar facet pain, they won't point necessarily in the middle. They'll say, you know, pain's like right here. It hurts when I bend back, especially like if it's on one side, it hurts when I go back to this way. And then they've done studies where they do injections, and they'll see where they do the injection, and then they'll map where the sensation goes down into the leg. So that, like I said, facet joints can radiate pain down the back of the leg, but they don't usually go below the knee. So like I said before, when we talk about extension, that's where you're compressing the facet joints. And you can get to the point where you have facet arthrosis. So when you have DJD in the spine, you want to divide it. There's two different parts. You can have it on the vertebra, vertebral body, and you can also have it on the facet. And that facet can encroach onto the IVF, just like it can do in the cervical. So you can have facet arthrosis in the lumbar spine. Okay. What I'll probably do is just print this onto maybe an extra handout so you'll have it in the notes so you don't have to worry about writing all this stuff down.
If you have like DJD of the vertebral body, what would be a sign and symptoms? You're not going to have anything radiating, are you? Or I just see that to say if it's the degeneration of the vertebral body, not the facet.
Yeah. Are those two lumbar ones that were floating around, are they in here too? Yeah. Okay. All right, so you're talking about arthrosis onto this surface right here.
Yeah.
Okay. What happens if it encroaches on the front here? Is there anything that's going to get affected by that? No. It just goes into your abdominal contents, right? What if it happens right here and it goes back right there? Can that affect anything? Yeah. So what happens is you can get spinal stenosis, you can get pain down into the legs. If you get spinal stenosis up here, it can affect everything all the way down.
When they talk about the disc or the body?
Degenerative joint disease, usually arthritis is going to be bones and joints. So it's not really the disc. Okay, degenerative joint disease is different than degenerative disc disease. Do they go together most of the time? Yes, they do. If the disc narrows, it's putting more pressure on the bone. The bones respond by laying down more calcium. That's what arthritis is. Right? So you can have degenerative disc disease and degenerative joint disease. But technically, the degenerative joint disease is the inert bony tissue, which is the vertebral end plates and the facets. So you can have degeneration here, you can have degeneration there. They can both affect the IVF, because if it's coming back here off of the vertebral body, it can go into the IVF right here, or if it's on the facet, it can go into the IVF this way too. So they can both affect it, because usually you're going to have the three things together. You're going to have the vertebral body, the disc, and the facets. So they all act together to compress that space, and then what happens is that as this disc goes down, it slips forward. So you have anterolisthesis. Right, and I think I've got some pictures of that too. So basically, if facets get irritated, they can develop arthritic problems, or they can just have acute things like with the joint capsule, or like loose bodies, or it's almost like a meniscus or a fold in the joint capsule can get stuck into there. So a lot of times when we're doing chiropractic adjustments, that's what we're doing a lot of times is facet joints. And then the other scenario with lumbar facet syndrome is you can have, and we'll talk more about that specifically, you can have, like in the neck, we talked about postural situations where you have crossed postural problems where you have these muscles are tight, these muscles are weak, you end up with this. Okay, so in the low back, These muscles get tight, these muscles get weak, you end up, with this type of posture. So chronic tight lumbar extensor muscles are going to do what to the facets? They're going to compress them. They're going to force you into more extension. You're going to have hyperlordosis. Okay? So these muscles get tight. They put irritation on the facets. Those can irritate the nerves. So facet problems can irritate the nerve roots. Because, without getting into too much of the neurology, basically there's a nerve branch that comes off of the nerve roots that go to the facet. If there's problems in the facet or misalignments or excessive nerve irritation, it goes back up and creates a short circuit in the nervous system, and then you can get that pain radiating down the back of the thigh that doesn't go below the knee. So here's the primary area where you have for facet syndrome or facet problems is in the low back, usually off to the side. It might go into the buttocks. The second area is down into here, and then uncommonly it can go down into the calf. All right, so now we're back onto what's into the notes. So now we're starting to talk about contractile tissues. So now we're moving into lumbar strain. So basically that's where the person, say, they lifted something, and all of a sudden their back's hurt. Now they're going to have that antalgic posture where they might walk in like this, or they'll be in like that, where basically those muscles have tightened up, they've stretched and torn the muscles. It happens from excessive lifting or faulty lifting technique. It can be either acute, or it can be acute exacerbation of a chronic repetitive type of thing. So they're going to have a history, they're going to talk about a specific activity they did, or repetitive bending and lifting. They can have apprehensive motion, they're going to have antalgia, they're going to get into that minor sign where they get up, they can go kind of like this. And obviously if somebody has a severe case, their range of motion is going to be pretty much zip. They're like, they come in like this, their right lateral flexion is minus 15 degrees. Right? They try to go like this, no, that ain't happening. Okay? But in some cases they have range of motion, they may be able to bend forward, and then when I'm doing forward, are my extensor muscles doing any work to bend me forward like that? No, not really. Once they start to work is when you come back up. So somebody will say, when you have any range of motion, they bend forward like that, is there any pain? No. And then they come back up and say, yeah, now it hurts. Now it hurts. So that's going to indicate to you that it's what kind of tissue. Contractile tissue, right. So you're activating the muscle. Okay, so they have pain. They won't have any pain until they start to come back up. So when they flex forward, they won't have any pain until they start to come back up. And then active, or if they don't have that, then active resisted range of motion is going to be. And then, originally in the notes, I think it said there's no special test for it. But if you do a straight leg raise, they probably, if it's a severe case of a lumbar strain with muscle spasm, when you do a straight leg raise, they're going to say, yeah, my back hurts. Okay? They're not having pain down the leg, it's not a nerve issue, but the low back is so irritated and inflamed that you're going to have pain on the straight leg raise, just in the low back.